Good morning. My name is Dr. Paul Tomazewski. I'm an orthopedic sports medicine physician, and today I'm excited to talk to you about the state-of-the-art meniscal repair. So what we're going to talk about today is what is a meniscus, the typical history and physical exam, classification of meniscal tears, meniscal surgical options of meniscectomy and repair. We're going to discuss advances in diagnosis and repair techniques, specific tear patterns, repair augmentations, and the outcomes that we have seen. So what is a meniscus? There are two wedge-shaped areas of cartilage between the femur and the tibia that function to distribute forces in your knee and act as shock absorbers. They bear 50% of the weight-bearing load when your knee is in full extension and 85% when your knee is at 90 degrees of flexion. They're critical to the long-term health of your knee. They preserve the hyaline cartilage at the end of your femur and your tibia. They provide stability as the secondary stabilizer to anterior and posterior translation. They provide proprioception, which is knowing where your knee is in space, and joint lubrication. Without your meniscus, your knee is at risk for progressively becoming painful and arthritic. So what do we see on normal history and physical exam? They may have had a recent trauma, such as a twisted knee, twisted on a planted foot, or concomitant ACL injury. They have pain, swelling, may have mechanical symptoms of locking or clicking. They may have an effusion, which is a decreased range of motion. They may have medial or lateral joint line tenderness. Some specific testing you can do are McMurray's, Apley's, or Thestley's test. And with a positive McMurray's and effusion and medial or lateral joint line, your sensitivity of diagnosing a meniscal tear is 95%, and your specificity is 88%. When you have a high suspicion for a meniscal tear, we then go on to a MRI, which will help us with classification and subsequent treatment of meniscal tears. So classification of meniscal tears, first we do whether it's medial or lateral. Medial is more likely than lateral. Timing, whether it's an acute or chronic tear, usually 8 to 12 weeks is our timeline of acute versus chronic. Tear configuration, whether it's a simple type tear, whether it's complex, vertical, horizontal, oblique. These are radial tear and some newer type tears that we've been able to really get a good eye on are root tears and ramp tears, which we'll discuss in a little bit. The menisci are the location of its blood near its blood supply is also very important. As you go from the capsular more central into the knee, the blood supply gets less and less. So at the red zone, which is near the capsule, is where the most blood supply is and the highest likelihood of healing, to the white zone, which is towards the central part of the knee, which is the least amount of vascularity. And then the status of the hyaline cartilage, or the cartilage at the end of the bone. Is it worth saving that meniscus? Do you already have significant arthritis in your knee already? And then tissue stability and tissue quality and stability is something that we look at when we get in the joint. Will it hold a stitch? Is it repairable or not repairable? Is it stable or is it not stable? So your treatment options for meniscal injuries are non-operative and operative. Most people will have resolution of their symptoms with non-operative treatment of oral anti-inflammatories, physical therapy, and a possible cortisone injection. However, those people who do not have resolution, they have operative interventions, which can include a meniscectomy and meniscal repair. We also look at concomitant injuries for ligament stability and limb access. Let's talk quickly about meniscectomy and then get into repair. For a meniscectomy, the pros are there's a 20-30 minute procedure. You have immediate weight bearing. It's a relatively quick recovery, low risk. Cons are that every 10% loss of your meniscus that you have increased contact stress by 65%. And there's a direct relationship, the amount of resection and the progression of knee osteoarthritis. So we want to save as much of the meniscus as possible to maintain the normal knee kinematics. So treatment options for repair, the pros are it preserves and protects that hyaline cartilage at the end of your bone. It restores normal biomechanics. The patient-reported outcomes are better. The activity level is better, and there's better long-term results. The cons are it's a longer surgery depending upon the tear type and the repair complexity, higher upfront costs, and possibly a longer recovery of partial or non-weight bearing afterwards. And there's a higher risk of neurovascular injury as well as a higher risk of reoperation compared to meniscectomy. various different techniques for repair. Most are done arthroscopically now. Sometimes there still is some open repairs, but most done arthroscopically. All inside is meaning that all of the suturing is done inside of the knee joint through the two portals. Outside in is we're coming from the outside of the joint to inside the joint and tying on the capsule. And inside out is passing needles from inside the joint to outside the joint and tying again on the capsule. That is considered the gold standard for meniscal repair. There's some recent advances in devices and techniques and diagnostic tools that allow us to better understand the biomechanics of the meniscus. Two specific types of tears are what are called ramp lesions, which is a posterior capsular dissociation, and a root tear, which is an avulsion of where the actual meniscus attaches to the bone. Those are two type tears that we have come to really understand more and more over the past 5 to 10 years. Different types of repair devices gives us better structural integrity at time 0 and better restoration of load sharing. So looking at all inside versus inside out, really there's no difference in failure rates and outcome scores. The healing is comparable for inside and all inside versus inside out, but it's depending upon the tear pattern and actually association with an ACL injury. We know that ACL injuries and meniscal tears, the meniscal tear will heal better with that ACL tear. But there still is a 20% failure of both of those types of repairs. So each different types of tear has a specific type of repair that's better for it, but you can use any different type of repair, whether it's inside out, all inside, or outside in, or a combination of all of them to get the best and most robust repair that you can. So talk about a couple of specific types of tear patterns. The vertical tear, or what can become a bucket handle tear. If this is removed, it can be almost leave like a subtotal meniscectomy and really leave you without a significant amount of your meniscus. So we tend to repair these bucket handle meniscus tears when they get over 10 millimeters in length, and you can use all inside or outside in techniques. Again, there's no real difference in the outcomes, as we will see. Radial tear is a tear pattern that goes from the capsule through all 3 vascular zones, or can go through all 3 vascular zones. And historically, these were treated with a meniscectomy. But more recently, we have better data that show that they have survival rates of about 80% at 3.5 years. And there are many different repair techniques that you can use. Again, all inside, inside out, combination of the two to really get a robust repair. Horizontal cleavage tears. Historically, these were meniscectomized because the upper leaflet or the lower leaflet, as you can see on the top right-hand corner, was taken out. Now we do more of almost like a sandwich technique to get those two to heal together, again, to retain as much meniscus as possible. And we have seen about a 76 to 80% success rate in these. Root tear is one that we've really come to understand a little bit better over the last 5 to 10 years. These are difficult injuries to diagnose on physical exam. They don't show the classic signs. MRI, there's a classic sign called the ghost sign. You can see on the upper right-hand corner where that meniscus is no longer visible. You also get meniscal extrusion. And these are important because every time you take a step and you have a root tear, your knee will push that meniscus out of the way, and you basically have point-to-point loading on the femur, on the tibia. And you will go on to arthritis much more quickly than you would have if we repaired them. And that's what we've been doing, is definitely repairing these through a transosseous technique or a suture anchor technique. So how can we augment our repairs to get a better healing? We can do this through mechanical, biologic methods, and it aids in the defect closure by adding cells or bioactive growth factors or cytokines to recruit cells, add in the vascularization and angiogenesis, decrease the inflammation, and all for healing of the meniscus. We can do this mechanically through microfracture, which is allowing marrow elements to egress, usually done in the notch of the knee, trephination or poking holes in the repair site, and with a concomitant ACL reconstruction. Biologically, we can add PRP, mesenchymal stem cells, fibrin clot, or other type of cytokines and growth factors. So what are the outcomes? Age, we historically used age as a kind of a cutoff of whether we would repair meniscus or not. Now we know that outcomes after meniscal repair is not age dependent, and 40 is kind of the number of people look at. Before and after 40, the results reveal that there's no significant difference when we repair these in patients less than 40 and patients older than 40. Again, a minimum 10-year follow-up. Patients younger than 40 and compared with patients older than 40, repair failure rate was not different between the two groups. What are the long-term outcomes after arthroscopic meniscal repair versus meniscectomy for traumatic meniscal tears? We see the midterm results. There's no significant difference in osteoarthritis, but there is better sports activity in the repair group. But as we go to long-term results, after partial meniscectomy, we see a highly significant osteoarthritic deterioration was detectable compared to those that had a meniscal repair. And that's important that we maintain that meniscus to protect the cartilage to prevent that osteoarthritis. So in conclusion, we want to save as much meniscus as possible. Tears with concomitant ACL injury do better when they're repaired. Vertical tears do a little bit better than horizontal or radial tears. Tears in the vascular zone have a greater healing potential than those in the avascular zone. Degenerative type tears have worse outcomes. Age is not a huge factor, but definitely as you get younger and younger, you want to preserve as much of the meniscus as possible. And successful meniscal repair requires a full repertoire of repair techniques and augmentation if needed. But you have to counsel your patients that there still is a failure rate of up to 20%. And then we want to do what's best for the meniscus and the patient, not what is fastest and easiest.